So the combination of immunotherapy and chemotherapy is quite an interesting prospect, and there are multiple phase 3 trials going on now in the first-line setting, comparing either monotherapy to chemotherapy plus checkpoint inhibition and chemotherapy alone, as well as Checkmate 901, which is comparing ipilimumab and nivolumab at the IPI-3 Nivo-1 dose to chemotherapy without a checkpoint inhibitor. The hope is that we'll see higher activity with immune combinations, either immune-immune or immune chemotherapy combinations. But we really have no data at this point in bladder cancer. We see the data from lung cancer, and that makes us excited, and perhaps that bladder cancer seems more like lung cancer in certain ways nowadays, where there's a requirement for PD-L1 testing in the first-line setting in order to get single-agent checkpoint therapy. And that was recently data that was released by the FDA and the EMA with restriction of the labels requiring patients who are cisplatin ineligible to have high levels of PD-L1 in order to be eligible to get immune checkpoint therapy based on inferior survival in KEYNOTE-361 and IMvigor130, although we haven't actually seen that data. And so we look forward to seeing the data from those randomized trials to understand what the decrement in survival was for patients who were PD-L1 low receiving immune checkpoint inhibitors.